So I'm here really to give you a primer. So my topic is Liver Cancer 101, and what you're going to hear is sort of in broad strokes how we approach liver cancer, and then the subsequent speakers are actually going to break it down a little bit more. The reason that I didn't prepare slides is because I think that it's very hard sometimes to assimilate a lot of information when it's coming at you from many different sources. And really the intent of this conference is to, really try to explain things in a way that you're empowered to ask questions, to pick our brains, to really feel like the most valuable player on the team, which is what you are. So we're going to talk about liver cancer. And I think it's important to know that there have been tremendous developments in liver cancer in the last 10 years, such that we now have many more therapies available for patients with liver cancer. And we really are getting a sort of flavor for how to handle this cancer in a very highly individualized way, so that liver cancer is a latecomer to precision medicine. But what we really want to do is have each patient be the center of their own team that comes up with the best plan for them. Okay, so let's talk a little bit about why liver cancer is challenging. It's challenging because more often than not, actually really in about 90% of cases, liver cancer arises in a patient who already has chronic liver disease. And so essentially you're trying to treat two diseases or two problems. One is the chronic liver disease, and then the other is the development of a cancer in that chronically inflamed or scarred liver. And that actually makes some limitations on how we approach this cancer, because the organ itself is damaged, and we need to be sure that we allow you to have as much good liver function as possible to handle the therapies for the liver cancer. So we essentially have one patient with two distinct diseases. And we know that cirrhosis or scarring of the liver leads to a fertile ground for cancer to grow, but oftentimes multiple cancers. So it's not just one spot of cancer, it may be multiple or recurrences over time. So it is a chronic thing that needs to be followed very carefully from the moment of diagnosis of liver cancer. And we know that cirrhosis does complicate not only how we consider treatment, but also how we design clinical trials to really determine the best treatments in the future. Liver cancer is an unusual cancer. It's the only solid organ tumor that can be diagnosed by imaging alone, meaning not everybody is offered a biopsy. And there's some consequence to that, in the sense that we're able to make a very definitive diagnosis with imaging in the right patient, a patient with cirrhosis. But without a biopsy, sometimes we're not exactly sure sort of what could be the best treatments in the future. So right now we don't have tumor profiling available for liver cancer that allows us to really determine the best possible course of therapy, but that's not to say we may not in the future. There are certain types of liver cancer, cholangiocarcinoma, for example, that tumor profiling does help determine treatment course. I'm really focusing my talk on hepatocellular carcinoma, or the cancer that arises from the liver cells, not from the bile cells. The other issue that makes liver cancer a very unique cancer is that it's also the only solid organ malignancy for which liver transplantation offers a durable cure, and a different sort of cure than the type of cure that most oncologists look for. So most oncologists are very happy when they can achieve, a 5-year survival that's pretty high. Whereas in transplant, you're really looking for 5-year survivals that are, in excess of, 80, 90%. And so there's a difference in the calculus of survival for that particular treatment. And so it's a very important conversation to have. And really, if we can detect liver cancer early, when it is transplantable, then we can actually afford a decades-long cure from the cancer, but we're also removing the sick organ, the organ with the scarring and the inflammation of cirrhosis, and really giving that person, a healthy liver, and one that won't be prone to developing cancer. So where at all possible, that is something we really ought to strive for. But many, many patients are diagnosed and they are not transplant candidates, or their cancer may be too far along to consider transplantation. And by no means are they without options. In fact, they have plenty of options. So in terms of liver cancer, we have to think a lot about the epidemiology, or where exactly do people live who get liver cancer, and what are their underlying liver diseases? And that epidemiology is changing. So in the past, a lot of people in the United States had hepatitis C. That was the cause of their cirrhosis and their liver cancer. We've been able to treat hepatitis C. It's very important to get hepatitis C treated because you're actually eliminating the virus and eliminating the risk factor for cancer. If you have cirrhosis, even with hepatitis C, you should still get your hepatitis C treated because it reduces your risk of cancer. So hepatitis C has changed in terms of the natural history of what we're seeing. We're seeing fewer liver cancers in patients who've had hepatitis C and been cured, but still they remain at risk if they have significant scarring. So it's very important for you to know where you stand in that spectrum of having scar or not prior to your hepatitis C therapy. But we're seeing more and more, apart from hepatitis C, which is on the decline because we can treat it and cure it, fatty liver disease leading to inflammation and scarring and cirrhosis. And fatty liver disease is important because it has a different course, it has a different natural history, and one that we're just beginning to understand. But it also carries a risk of cirrhosis and liver cancer. So I want you to be getting the feeling of the fact that cirrhosis is usually sort of where you have to be before you develop a liver cancer. That's not always the case. The other group that's very important to remember is hepatitis B. Hepatitis B can actually give rise to liver cancer in the absence of cirrhosis. And so we need to be vigilant in patients with hepatitis B. So this epidemiology is shifting. The other very important etiology for liver disease that often is not discussed is alcohol. Alcohol-related liver disease is probably the most prevalent cause of liver disease in the world. And alcohol, once it damages the liver to the point of developing cirrhosis, those patients too are at risk of developing liver cancer. And so these different underlying causes of liver disease, once the person develops cirrhosis, they can all develop liver cancer, which is why anybody with cirrhosis should be in a surveillance program for liver cancer. And Dr. Guy is going to give you a lot more sort of education on who to screen, essentially everyone with cirrhosis, and also those patients who have hepatitis B who may go on to develop liver cancer without developing cirrhosis first. So that surveillance is very important. If you have cirrhosis, you should be undergoing ultrasound screening every 6 months. And there are people for whom ultrasound may not be sensitive enough. And there are other recommendations in those people for what we call dynamic imaging, like a CT scan or MRI. And that's done with contrast, very sensitive. That's more of a diagnostic test than a screening test, which is why ultrasound is used as a screen because it's cost effective. Once we have a mass noted on ultrasound, that's actually when we move to a diagnostic test. And that diagnostic test is CT or MRI. It's a specially protocol test to really make sure that we're looking at your liver with the most sensitive possible way. And we have very good ways of reading those exams that give us an index of suspicion of whether this mass is something simply to watch or something that may become a liver cancer or already is a liver cancer. And so those kinds of questions are important to ask your doctor if they say, oh, we found something on your ultrasound. Well, what's next? It's probably going to be a CT or an MRI. After that, they'll come back and let you know the results. And you want to say, what type of mass is this? Do I need to be concerned? What's my follow-up? Because every way that we characterize these things that we see on CT or MRI gives us an idea of how frequently you need to come back for imaging. So that always should be a question. When do I need to come back? Okay. Once we have a bona fide cancer, which we can detect by imaging, then we either say it's a cancer because it meets all the classifications by imaging, or we may be concerned that it may not, in which case you will be asked to have a biopsy. And a biopsy is a simple procedure. It's done without needing to stay in the hospital, essentially taking a small piece of tissue from your liver that they can look at under the microscope to determine if it is indeed liver cancer, if it may be a different type of primary liver cancer, perhaps a biliary tract cancer or something else. So getting a biopsy gives you that definitive answer. Is it liver cancer or is it not? Okay. Can they miss sometimes with biopsy? Absolutely. There may be times when you are asked to get a second biopsy. And I think it's important to understand that certainty in terms of what we're treating is very important to us. And so if you're lucky enough, I mean, I wouldn't say lucky is the right word, but if your imaging is so characteristic that we don't need to do a biopsy, that's great. But if we ask for a biopsy, it's usually with very good reason. Okay. And many of us think the field may be moving to the point where biopsy may inform treatment, in which case biopsy is helpful for us. So I think these are all very important conversations to have with your doctor. You know, are you going to be recommended a biopsy? If not, why not? If so, why? That kind of thing. So bear that in mind if you're told that, you know, the what they're seeing on CT or MRI is concerning for cancer. Once we have a diagnosis of cancer, the next thing we do is staging. And that's when we actually try to make sure that we know exactly where this cancer is and that it hasn't traveled elsewhere. So in the liver, the game changers for traveling elsewhere are when the cancer goes into the vessels of the liver or when the cancer is found somewhere else in the body. Those types of cancers are called advanced cancers, and they have to be treated a little bit differently than cancers that are confined to the liver. So when you ask about staging, it's important to understand what stage, you know, your cancer is at and what are your available treatment options. Usually before you even speak with your physician about your treatment options, they've already thought about it a lot themselves. And that's something that I think patients and their loved ones may not be aware of, is that there's a lot of work that goes on behind the scenes to really discuss your case and what is the best treatment for you as an individual. And that's done in the setting of a tumor board. And so a tumor board is a large group of people that come together to discuss these cases frequently with expertise from many different disciplines. Like radiology, they read the exams. Like pathology, they read the biopsies. Like hepatology, the people who take care of your liver disease. Oncology, the people who would treat the cancer. Interventional radiology, those are people who actually will, you know, manage the local therapies to your cancer, as well as palliative care specialists, social workers, care coordinators. There's a lot of different people in the mix, and really they're focused on you. So when you think about a team, it's a big team. You have a big team. You may not always meet those team members, and you may meet them at different appointments. But the point is that there are a lot of people thinking about your case. And we want you to be thinking about your disease, about your goals of care, about your wishes, about, you know, who you want to have a second set of ears at this meeting where you're talking about your diagnosis and prognosis and the treatment path. So make sure you think about those things, because we're thinking about them too, and we want what's best for you, but we won't know what's best for you until you tell us, you know, how you want to live your life. You know, it's your body, it's your life, it's, you know, you're in charge, so to speak. So once we have the tumor board and we come up with a plan and we've staged you, and staging actually happens usually at tumor board. There are exams that are done for staging, like chest CT, for example, other staging exams if needed. We'll come to you with a plan. And then the plan is really based on your stage. So there are many different types of therapy for liver cancer. There are local treatments that are done with either curative intent or palliative intent. So some of those treatments can be done through the skin, percutaneous treatments where we burn the tumor, for example. They can be done laparoscopically with a surgeon if the tumor is difficult to reach through the skin. You can have a surgical resection or an actual removal of the tumor, and that's usually reserved for people who have very good liver function. Transplantation, again, removing the liver and replacing it with a new one. Those are all considered curative. More palliative local therapies. So the liver cancer is still confined to the liver, but it's not in the vessels or in the rest of the body. There are palliative therapies that are intended to keep the tumor at bay in the liver. And those are transarterial therapies like transarterial chemoembolization or radioembolization that either use chemotherapy or radioactive beads to treat the tumor, but they aren't considered curative. And that's usually in people who have large tumors or many different tumors. And all of this is based on guidance and clinical trials and many clinical studies. But still, we have to think about you, the individual, when we're making these decisions, and what are your choices in terms of a more aggressive approach, a less aggressive approach, your other medical problems, any contraindications. It all has to be taken into account. So it's not algorithmic. It's not like we have a cookie cutter algorithm that we say, oh, yep, you fit this profile, you're going to get this. We actually have to really think about it very carefully. Once the tumor has either breached the vessel or gone outside the liver, we think more along the lines of systemic therapies. And those systemic therapies involve medications that can be given by mouth or can be given intravenously, sometimes singularly and sometimes in combination. These medications are not conventional chemotherapies that you might have heard about in the past, where they cause, terrible nausea and vomiting, or, loss of hair, or, erosion of the mucous membranes. Those aren't the type of therapies we use in liver cancer. We use more molecular and immuno-based therapies that affect the immune system or affect the way that the tumor grows or develops its own blood supply. So very different side effect profile. You're going to hear much more about all of this from the other speakers. But again, a side effect profile is very important. It's important that you ask, what are the side effects with this medication? We have pharmacists that help us run drug-drug interaction checks to make sure that any of the medicines you are on aren't interacting with these other drugs. But still, you want to have a very good idea of what you're getting into, what you're going to be taking, what's the plan if perhaps you can't tolerate that therapy, or if perhaps you have growth of your tumor on that therapy, what's next? Once you have a therapy, you are then in a surveillance pattern to see what are the effects of those therapies. So we want to continue to do imaging and continue to assess your response. Some people are very fortunate and they have a complete response. Other people don't, and we have to, think about changing options. And I think that it's important to remember that cancer therapy has evolved so rapidly and radically over the last 2 decades that many people actually can live a good quality of life with a cancer that they manage chronically. And so, I think when people hear the word cancer, they sort of take a step back and, they think their world is coming to an end. And I think the truth is that their world is not coming to an end, but you do have to regroup and think about how to move forward. And the team is really there to help you think about how to move forward and to live with this cancer in a way that you can still live and enjoy your life. So again, I think it's important to remember that while our options may have been very limited in the past, they're not limited anymore. So it is getting to be a much better time in the treatment of liver cancer. I think it's also important, if you don't have liver cancer, perhaps you're at risk for liver cancer, you have liver disease, to really think about how to engage in lifestyle modifications, if you can, to help with prevention of liver cancer. So you'll be hearing a lot about prevention as well. I think the take-home points that I have for you today is, really to understand that our own understanding as physicians and scientists of liver cancer and predominantly hepatocellular carcinoma, our understanding is evolving rapidly, and that really affects the entire continuum of care. So there are clinical trials ongoing. There are many, many different studies. We're hoping to have biomarkers where we can, look at risk and prognosis and response to therapy. And all of this is coming down the pike. So it's a very interesting and really amazing time in the study of liver cancer. We do have to embrace technology, complexity, and team-based care. So there are a lot of different ways that we practice science and medicine now. And we really have to do this in a way that affords our patients precision, individualized, best possible outcomes. We know from studies and from our practice in liver cancer that a multidisciplinary approach is the mainstay for our decision making, so that we do come together to make these decisions as a team. And ideally, we should always be pushing the envelope, and that is usually done in a clinical trial setting, so we can be sure that we're pushing the envelope in the right way. And the only way we can advance science is through scientific discovery in clinical trials with patients. And so I have to thank every patient who's ever participated or wants to participate in a clinical trial. And so I think in the future, we'll see a real surge with our large scale observational and sort of omic data, genomic, proteomic data that will help inform trial design and also determining biomarkers. And we really should think about how we're going to be studying these new medications and where they fit in the treatment paradigm for liver cancer. Again, liver function is always the most important deciding factor in your treatment therapy and the cascade of your treatment. And remember that there's really new discoveries coming, and we're very excited.